in a time where the pandemic has caused us all to pause and look for hope. What excites me most about what I've learned from these three experts is that there is tremendous hope, that virtual care and artificial intelligence, and these are the things that will help inform the future of emergency medicine. And so how wonderful. So very quickly, I'm going to stop talking, but I have to do them justice. Commander Shannon Leduc, again, a paramedic and commander of clinical programs with the Ottawa Paramedic Service, manager of a team of more than 50, I think it's even more than that, recently graduated with a master's of clinical and epidemiology, the first paramedic to do that in Ottawa, only ones to do that in our entire country. She's doing a lot of research in partnership with the Ottawa Hospital and looking at those opportunities to provide care in the community that in some cases ensures that patients don't need to come to the hospital. She is also a busy mother of 2 teenage boys, and this shows her tenacity. When you wanted to join the paramedic Marine team, you didn't know how to swim, you learned to swim as an adult. And so I commend you for that. Dr. Vank, such an incredible colleague as well, an esteemed emergency physician and senior scientist with the Ottawa Hospital, clinical research chair in cardiovascular emergencies at the University of Ottawa, an expert, if you will, in fainting and chest pain for some of the most common reasons that patients will often come to our emergency department. You are known, Dr. Vank, for developing the Canadian SINSCOPE risk score that again is used throughout the world. And I love that you have such passion when you speak, and that your other passions include music and cooking and reading for fun books on artificial intelligence and life lessons, as you so aptly share. It's wonderful. And last but not least, Dr. Christian Viancourt, again, such a wonderful professor of emergency medicine and senior scientist at the Ottawa Hospital, clinical research chair in emergency cardiac resuscitation, and an associate medical director for the regional paramedic program. Again, your wonderful and critical research focused on cardiac arrest and trauma, so critical, and again, so pivotal for our emergency department. Again, you've made this a family affair. Your wife, Karen, is a nurse at the Ottawa Hospital. Your 2 daughters you share proudly are nursing students and help in that regard. And I'd be remiss not to share this with our wonderful guests, that you are a member of the Triathlon Canada's team, that you went to Spain in 2016 to represent Canada and to BC in 2017, and that you will be a triathlete representing our country later this year. Just remarkable. So with that, I am going to invite our staff. You can see we've got some incredible team staff here. So Dr. Viancourt, maybe what I would do is invite you to start. And so I would ask you to speak for the next few moments about why research? Why focus on emergency medicine research when you're already got such a busy job saving lives? What inspires you to do that work? Is there a patient or a story that informs your work? And perhaps what's giving you hope? And so over to you.
Of course. So thank you for the generous introduction, Jennifer, and thank you all for joining. My brief story actually starts on the ski slopes. So a while ago, I used to be a downhill ski racer, and my father, who was otherwise not a healthcare professional, used to be a ski patroller. His friends and the people I interacted with as a young kid were paramedics, ambulance technicians, firemen, some nurses. So that kind of fostered my interest in emergency medicine. A little bit later on, as a young physician resident at McGill, I also collaborated with Urgence Santé, which was their pre-hospital equivalent of our Ottawa Paramedic Service in Montreal. And I used to moonlight there as an emergency physician on the road, which is a system they had at the time. Often overnight, I was the only advanced life support provider for a population of 1.5 million people around Montreal and Laval. So I loved doing this work. We were driving really fast, north, south, east, west, to provide care to cardiac arrest and major trauma victims. But over an 8-hour period doing this, I may have interacted with possibly only 4 patients. I figured in the emergency department, I could have a much bigger impact, seeing 20, 30 patients at a time. And Dr. Vank, Commander Leduc, and I are very blessed to have the opportunity to work as part of a team to provide resuscitation care to cardiac arrest victims and bring some of them back to life. But there again, I figured that over my entire career, I could possibly save the lives of 15, 20 cardiac arrest victims. That's certainly very meaningful for these victims and their family. But through the research we do at the Ottawa Hospital, through the Ottawa Hospital Research Institute as well, we estimate that the work we do in the field of pre-hospital cardiac arrest research actually saves probably 1,000 lives each year. So that's why I do this. But perhaps more importantly, because of this work, we also get to interact with our cardiac arrest survivors and with their families. We have a group of them with whom we meet every year. We actually get to meet in person, which is a great privilege and not something that we do very commonly, even from the emergency department. And many of these survivors are now integrated with our research team, helping us decide in which direction we're going, but also helping us to see things from their perspective. So that is why I still, after many, many years, still have the passion to continue working in the field of cardiac arrest.
Amazing, amazing. Well, I thank you so much for that, and we'll dive in because I already see a couple of questions, which is wonderful. Commander Leduc, perhaps I could move to you next, if that's okay. And again, maybe the same questions: why and how research on top of the work you're doing, what inspires you, and what are you most excited about, hopeful for?
Sure. I think to start, I was always that curious kid with a million questions, and I have not grown out of that yet. I don't know that there's hope for that. And I've been a paramedic for 20 years now. And in that time, I've seen quite a lot of change and quite a lot of growth and development in the profession and in paramedic care. And, you know, over that time, I've really become increasingly interested in understanding different ways that paramedics can serve patients and care for patients and help contribute to relieving a little bit of the stress that the healthcare system is facing today. So that's kind of led to my research interests, which are community paramedicine and alternative models of paramedic care. And specifically, I did have one patient encounter that kind of inspired my more recent work and my thesis work. And that was caring for a patient from a long-term care center who you know, had a suspected bladder infection. And the long-term care center couldn't provide the clinical treatment that they needed. So we were called to bring them to the hospital. But unfortunately, when we got there, there was a long wait, a very long wait. We waited for over 4 hours in offload delay. And one of the things I remember about that patient is when we first met them, they were very, very gentle and soft and kind, and really, really worried that they were wasting our time or taking up resources and didn't want to be a bother. But you know, the longer we waited in offload delay, the more that patient kind of deteriorated, and the stretcher wasn't comfortable, and it aggravated other issues, and they became more agitated and, you know, confused and distressed. And when we did finally, we were able to transfer that care to the hospital, the patient was in a very different state than when we first met them. And it really made me think, you know, there has to be a better way to care for these patients. There has to be a better way to model that care around them and what they need. And so that sort of led to my recent research work. And I think for what I'm most hopeful for or excited about would be to see more paramedics involved in and leading research so we can continue to try and work on those questions that paramedics specifically see and those problems that we encounter and start to ask, you know, how can we make things better?
Outstanding. Thank you so much, Commander Leduc, for being with us. And again, then I wonder, Dr. Vank, if we could hear from you as well. Again, the same sorts of questions, and I know you're always so passionate when you answer as well.
Yes. So the passion comes from my dad. My dad, a simple man from a small hometown in India, suffered meningitis. When he suffered meningitis, he was given an injection antibiotic. He became completely deaf and blind in one eye. And he was admitted to medical school and was, at that time, there is no concept of equality and inclusion, and was very promptly said that he will not be fit for medical school because he was deaf. And then he went on to civil service and won the President's Award for the country. And that made me feel that I need to help people, specifically when they get into emergencies, when nobody else is able to act. That's when I want to act. When I slowly realized that that alone will not be enough, we need to move forward. We need to introduce innovative treatments, innovative solutions if we want to make our patients' lives better, save their lives, and make the system better. Fast forward, I come to Canada, and then I work in a small town, and I see patients fainting and with chest pain coming to the emergency department. And they used to work in a place called Lindsay, Ontario, outside of Toronto. Very complicated, how to wait for long periods of time before we can give solutions to them. Wanted to take this problem and make some improvements. And what is it that I'm really hopeful for is the huge amount of innovations that are happening during this COVID era. When everything is turning virtual, we are now able to monitor patients' heart rhythm virtually by sending them home, and they are monitored live 24/7. We can just know if there's any irregular heartbeats that are happening with them. We can reduce their time in the emergency department by having highly sensitive cardiac tests called troponin. All of these give a lot of hope and will for sure make our system better in the near future.
It's wonderful. Thank you. Thank you for sharing that. It's helpful to know what is inspiring each of you to do the work that you're doing. And I would say that's helpful to know as I look at some of the questions, because it's that this is not a job, this is very much a calling. And so I wonder if I could direct perhaps the first question to Dr. Vaillancourt, which is a question about cardiac arrest and the research that you're doing in that regard. How does one survive a cardiac arrest? And is there research that you're looking at right now that is helping to inform the work that you're doing?
Well, how you survive cardiac arrest, it takes teamwork, and not the least of which is what the community can do as well by learning CPR and initiating CPR while we're waiting for the paramedics to arrive. So I know you all know CPR, and you will learn it very soon when COVID allows us to do this. But we concentrate our efforts really both inside the hospital and outside the hospital for cardiac arrest. And this may be very surprising to people, but we discovered a little while ago that the response time to a cardiac arrest which occurred inside the hospital was actually slightly longer than in the pre-hospital field. We can expect to have a paramedic, a firefighter, or even a police officer show up to the scene of a cardiac arrest in the field in about 8 minutes with a defibrillator. In the non-critical care, non-monitored areas of our hospital, that response time was about 12 minutes. And the reason for this, and again, this might surprise a lot of people, is that our very competent and trained nurses can actually use an AED or a defibrillator in a community, but they're held to a higher standard when they are in the environment of a hospital, and they were not allowed to use an AED during cardiac arrest. They could start CPR, and then they would have to wait for a specialized team to show up to provide defibrillation, which is life-saving. So our first innovation at the Ottawa Hospital was to have every single physician sign into a medical directive allowing the nurses to actually use our defibrillators in an automatic modes. And with this, we've been successful at providing shocks to patients who needed them in less than 3 minutes. And that actually improved survival for our in-hospital victims of cardiac arrest. In the community, what we've discovered, probably 15 years ago, we published the very first national statistics on cardiac arrest in Canada in the pre-hospital field. And at the time, we noticed that only 15% of our cardiac arrest victims in the Ottawa region received CPR from a community member. 1 in 8 only. The rest of the country, that number was not 15%, it was closer to 30%. And at the time, we had no idea why there was such a difference in Ottawa and Ontario compared to the rest of the country. We later discovered that we were the last province in Canada to actually adopt a strategy where the 911 communication officers can actually provide CPR instructions to people calling, reporting a cardiac arrest. So we've done a lot of work in that field since then, and you will be happy to know that our community bystander CPR rates have now joined and surpassed the rest of the country, and so has our survival. You are now today, compared to just 20 years ago, at least 5 times more likely to survive a cardiac arrest event in the community compared to what was the case in the late 90s. And this is a field where we're continuing to make a lot of efforts. We can come back to this perhaps later. I don't want to take everybody's time, but we're investing a lot in the training of our communication officers, and even also involving artificial intelligence to make their performance even better and faster every time.
I think that's incredibly helpful. And of course, all influenced by research, emergency research, as you're seeing those different narratives. I love it. And maybe the quickest of follow-up questions, that just curious about what is the wait time then in the ER for a patient presenting with a chest pain? Do you have a sense of that?
Oh, so perhaps the big difference that we need to make is the difference between chest pain and cardiac arrest. So when people have chest pain and they're experiencing a heart attack, they're often still conscious. They can actually interact with us, communicate with us, complain about their chest pain. Right. We do a cardiogram very, very quickly, and even the paramedics do this in the field. And if we identify either in the emergency department or in the field, and the paramedics identify a myocardial infarction, they go straight to the Heart Institute, and that happens very quickly. It's not first come, first serve in the emergency department. There might be the perception that wait times are very long, but that's the reason why there's a triage system. We identify very quickly who needs help right away, and people who need help right away receive it right away. A cardiac arrest, on the other hand, is when the heart stops completely, the victim collapses on the ground, and they often don't breathe or have an abnormal breathing. And this is death if we don't intervene within minutes.
Yeah. Very helpful. Thank you for that. And again, I'm glancing to the right just to look at some of the questions, but thank you for that answer and appreciate the sensitivity in that regard. I wonder, Commander Leduc, if I could ask you the next question, and it's about this partnership between the Ottawa Hospital and the paramedics. And can you elaborate a little bit on the community care? So what does that mean, and how are patients in Ottawa getting the best care informed by research? What does that partnership look like?
Sure. So what we have in Ottawa is something called community paramedics, who are paramedics that have a little bit of an expanded skill set, where instead of responding to a patient with the intent of always bringing them to the emergency department, they will respond to kind of lower acuity type illnesses and calls, and do a little bit of preventative assessment and work with patients, with the intent of trying to provide care where they are, and when we can, avoiding those trips to the emergency department, whether it's something we can treat in that moment in the patient's residence, or whether we can prevent conditions from getting worse and to the point where they need to visit the emergency department. And so we've partnered on that with some of our research, looking at what specific conditions, in long-term care patients we could treat in that regard. And we've also partnered practically during COVID, where we created kind of a subset of community paramedics that were called the Special Population Response Team. And that team responded and provided care for a lot of the long-term care patients when those outbreaks were occurring. And we partnered with the Regional Paramedic Program of Eastern Ontario, which is part of the Ottawa Hospital, to provide that additional physician and medical support when needed. So these patients didn't always have primary care physician support available to them. And when that happened, we were able to call on physicians from the Ottawa Hospital to provide that extra support, but still keeping that patient in the community when we could.
It's wonderful. No, I think that's very helpful and assuring to know the system, if you will, and the approach to emergency medicine that way. Dr. Venk, I wonder if I could ask you this next question, and it's again to maybe zero in a little bit more on fainting and when one would present to the emergency department, and are there ways to prevent that? So a little bit of everything just around fainting, some questions around that.
Yeah, so
you're just cutting out a little bit there. Let's see, maybe I'll move on and hopefully, Dr. Venk, are you there? You just muted for a moment.
Yep, I'm here.
Wonderful, wonderful.
Okay, so yeah, fainting is a very common problem, and a lot of there has been a lot of issues in the form of identifying patients who are at risk for bad things happening to them versus the simple fainting that happens when you just see some blood or when you just meet people unexpectedly, when there is a shock factor. So we embarked on this research program to identify and develop a risk scoring system, which identifies people who are at major risk for bad things happening to them versus the lowest risk patients who we do not need to worry about and can be discharged home. So we developed it and we validated it across Canada, and it's now used all across the world. One of the satisfying things is that when you develop it and then you find that the patients are at risk for having an irregular heartbeat. And what also happens to the fainting patients is that they faint, they come to the emergency department, they are fine and they are discharged home. They go like this revolving door back and forth to the emergency department without any answers. And for that, when we know that these patients are at higher risk, we are now going to be putting in cardiac monitors for these patients before discharging them home. One of our first patients had such a monitor. She was from the province of Quebec, and it so happened that she was on the Ontario side because our work is on the Ontario side, and she ended up at that Ottawa Hospital. And she was the first patient to receive the monitor, and she goes home, and she was detected as having a ventricular type of arrhythmia, potentially lethal arrhythmia that would have caused death. On inquiring further, when we knew that some of her uncles had died unexpectedly and suddenly without any reason, and she went on to have a defibrillator, and she has had no more fainting episodes since then. So it is those type of research that we are interested and we have developed it. Following up on a couple of things that Dr. Valancourt and Dr. Shannon Leduc had said, we have just received a grant for identifying this ultra low risk or extremely low risk patients who call 911 after fainting. And we will be developing a tool where we don't have to transfer those patients to the emergency department. When we are fully developed, when we implement it, we are hoping to identify these extremely low risk patients. Valancourt's research on cardiac arrest is so important. Like, you know, if you want, yes, it's important to learn CPR. It's important to learn how to use the AEDs. The good story is that like I was on a plane, there was a sudden patient who collapsed. We started CPR, we applied the AED, we shocked this patient because he had an irregular heart rhythm, which was probably he was going to die right in front of us. He stood up, he walked out of the plane. So that's what it can do.
Isn't that amazing, eh? Just to see that the work you're doing is not only happening in the emergency, in the hospital, but outside the hospital as well. Thank you for sharing that. I see a couple of questions about technology, and I'm conscious of our last several minutes. And I think what I'd like to ask, maybe starting with Dr. Vaillancourt then, is either from a research project or a technological point of view, what are you most excited about what's coming? What are you working on or what's coming that you just would want folks to know about?
Yeah. So a big challenge which is faced by communication officers and with callers alike is that very, very early on during cardiac arrest, although the person is unconscious and on the ground, their brain stem is still stimulating the occasional gasp or abnormal breathing. And of course, if you're calling about a family member, which is the most common situation, most cardiac arrests happen at home, you're going to be clinging on to any signs of life. So when someone takes a sudden gasp, you want to be in denial that this person is in cardiac arrest. That's challenging for the caller, the family member, but also for the communication officer over the phone to recognize cardiac arrest. So we've made great efforts, and we're currently teaching them, providing them with additional information on the significance of abnormal and agonal breathing. But we're also initiating now some work with artificial intelligence and neural networks to try to listen in on these conversations. And the goal will be in the very near future to be able to assist 911 communication officers and have this artificial intelligence listen into the conversation and giving them more accurate and faster advice on when to start CPR instructions and save more lives this way.
Oh, it's
Really
wonderful.
excited about that.
Thank you for sharing that. And maybe the same question of you, Commander Leduc, next. Again, is there, again, with such a focus on new technology or projects, is there something you would be remiss not to share in terms of what you're excited about?
Yeah, we're really excited about some of the new expansions with community paramedicine, where we're looking at those elderly patients in the community and providing extra care. We're partnering with a lot of different clinical groups to do this. So specialty care for chronic diseases like congestive heart failure, diabetes, etc. And something that we're implementing this year is a remote patient monitoring program. So we heard in the initial plenary address about using some of this technology to help patients monitor their health at home. We're doing that as well. And in partnering with some of these clinical care teams, in addition to us being able to monitor patients and hopefully prevent, increasing their condition, those clinical care teams are able to do the same thing. And when they're hoping for another assessment of the patient, they feel they need some hands-on or in-person assessment, rather than asking the patient to go into their clinics or into the hospital, we're going to be helping those patients by providing that care and assessment in their home. So I think that'll be a great addition to community paramedicine this year.
Outstanding. And I'm curious, I see a question here that says, are there any downsides to technology? Are there, for the most part, I get it, there would be some hiccups, but for the most part, it sounds like things are progressing well and that we need to forge this new ground. Is that a fair statement?
I think so. Yep.
Yeah. Dr. Vank, I wonder if I could ask you the same question, just in terms of, is there a particular project or a piece of technology that an advancement that you would like to speak with?
Virtual care and putting patients right in the center of their journey is going to be the key. I envision in the future that patients would come in and they would be able to interact, or even from home, they will be interacting with the computer, with their symptoms, and we will ultimately be able to decide where do they need to come in, when they can come in, how quickly they need some tests done, and what type of tests need to be done. And that's what we are working on. As an initial step, we are working on patients telling their story about their chest pain and fainting, and whether we can figure out whether it is a heart-related problem or not is the first step towards making that. I envision in the future patient coming, waiting to the emergency department, treated by an emergency nurse, making sure that the vital signs are fine, and they would just go and interact with the computer, and we would just have the list of tests that are needed, and they would be confirmed by an emergency physician at the end as to what is happening with them, explained. So they will get the personal care, but we will be advancing in huge amounts of artificial intelligence in order to decide and make patients safer.
I think it's evident from speaking with all three of you that we're going to need to do this almost annually so that you can give us an update on so much of the work you're doing. I know that we're going to be booted out in a moment, but I just want to thank you all so much. Often we sort of take for granted what you're doing on the front lines, what you're doing when a patient or a family is in crisis, but you're doing so much more than saving that life. You are ensuring that for generations to come, that care will be as good as it can be, and that's only growing. So I thank you for your insight and your thoughts. I'm excited to see where this field goes. And again, I hope everyone watching has learned something. So I thank you very much for that. So that ends this session. We're going to be kicked out in just a moment, but thank you all so much.
Thank you.
So I think we'll see where that goes in just a moment, but really appreciate your insight and your candor as we work through doing this virtually. It'll be nice to do this in person at some point soon.
Yeah, and armchair
moderating skills. Thank you.
Oh,
yeah.
Thank you. If we've still got our guests on the line, I encourage you to go to our resources tab and to the Ottawa Hospital Foundation website and the Ottawa Hospital website. There is some incredible information there. Happy to provide additional information at any time.
Get vaccinated and learn CPR.
I love it. I love it, Dr. Vaillancourt. Great advice.